Okay, so could you start by just telling me your name, your college membership status, and where you practiced, please?
Right, I'm David Kindley. I'm a fellow of the College of Edinburgh and London, but we won't mention that. And I used to practice at Sick Kids and the Raeden Centre with outreach clinics in Shetland, Elgin and latterly Orkney. That was where I practiced. It might be helpful if I told you how I got where I was. The biggest influence in my training was a paediatrician called Lewis Rosenblum, who was a paediatric neurologist in Liverpool, who specialised in the care of handicapped children. He would now be called a neurodevelopmental paediatrician rather than a handicapologist. He developed the concept of child development teams and had an integrated child development centre, the first in the United Kingdom. The second in the United Kingdom was Raeden, but more to that in a minute. I took a consultant job in Bury in Lancashire in 1982, and there I had a population of 200,000, a district of 8 miles in length by 2 miles in width. I got, am I allowed to say pissed off with the management? Because they wouldn't appoint a third paediatrician. I'd been on a 1 in 2 for 10 years. And I opened the BMJ job supplement and saw a job advertised in Aberdeen, which mentioned the Regional Child Development Centre and also said there may be an opportunity to do clinics in Shetland. That was all it said. So I applied for that job and got it. A brief word about Raeden, because that will feature in what I'm explaining. Raeden was opened in Aberdeen in 1970. It was a child development centre that included all the health service agencies. It included social work, it included education. It had a day nursery for children from 6 months to 3 years, a nursery for children from 3 years to 6 years. It had a headmistress and it had a medical director. Now, occasionally, Jean Brodie met Sir Lancelot Spratt, me, occasionally, but most of the time, the headmistress and I got on very well, and we got on well with the physios, the OTs, the occupational therapists. We had a hydrotherapy pool and all that. The only problem with Raeden was there was only one. And part of the package for Raeden was transport to and from it. You could only get transport to Raeden within a 20-mile radius of it. The reason for that was how long it took to bring the kids in, how much it would take out of the school day. That meant that there were brilliant services for children within the 20-mile radius, but not a lot out with the 20-mile radius. We started to try to pull together services in Elgin, doing clinics up there, but we'll go on to that as another story. The Shetland clinics basically were general paediatric clinics. We flew up on a Monday morning. We got Sinclair's taxis to the Gilbert Bain. We had a fight with the orthopods to finish their fracture clinic, which is first thing on a Monday morning, to get into clinic while the patients were piling up waiting. We then did clinic from whenever we got into the consulting room through till Wednesday morning, when we piled into Sinclair's taxis to try and make it back to the airport to get the flight back to Aberdeen. The world record for the number of patients seen in one clinic was held by my colleague who became an honorary professor, George Russell, who saw 105 patients in the time I have mentioned. I didn't top the 100 mark, thankfully. So that was general pediatrics. I started to gravitate towards specializing and looking after the children with handicapping problems. And I looked at how they'd done this in Scandinavia. I visited Finland, Norway, Denmark. I'd got my own experience in Bury, and I tried to bring together, and succeeded in Shetland, physios, OT, speech therapy, clinical psychology at the time, although we lost that, educational psychology, but not social work. I couldn't get them on board. And we realized that this Monday to Wednesday rush clinic wasn't the right place. So I, off my own bat, started doing 3-day clinics, 2 times a year, when all the rest of the team would be there. And at the end of the clinic, we would meet with the parents as a team and discuss what we'd found. That was called the Child Development Initiative, and that was what I exported to Shetland as my idea for managing handicap. It worked well if we had support in Shetland. At first, we had the support of an ex-Great Ormond Street registrar or senior registrar, married to a doctor in the south of the island, who used to come up and do the clinic. She then exported herself to Aberdeen to finish her training and become a consultant in, funny enough, paediatric neurodisability. I wonder why. And started developing teams out with Raeden. So there was trying to make things more widespread. That left a gap in Shetland. Shetland tried to appoint a paediatrician. She lasted for a year and had to leave for family reasons, and went south again. And the latter solution was a local GP with a diploma in child health, specific expertise in children. Am I allowed to mention the name?
Yes, yes, absolutely.
That's Dr. Susan Bowie of the Hillswick Surgery, who's about as far north in the mainland as you can get, who would travel down to do the clinics with me, and do the child development clinic and do the general clinic with me. And that worked well. So that was the Child Development Initiative, the team up in Shetland, which I'm sorry to hear is slightly deploted at the moment because they haven't replaced the OT, who's left, and the physio sadly has long COVID. Perhaps I shouldn't say that, but anyway, that was how it developed. I discovered in sort of general practice that there were some consultations that went, "Hello, how are you doing? That's absolutely great. Keep on taking the tablets. See you in 6 months." Did I need to? So I started asking, or getting the secretaries to ask the parents if they would be happy with a phone consultation at the time of their hospital consultation. And I started doing that, and it was of particular value for obvious reasons, for Fair Isle, where I would say 1 visit in 3 was weathered off, and Unst, where it wasn't quite as bad. But again, it's a long way, and us soothmuffers don't know quite how far it is. So I started doing telephone consultations, and I exported that idea from Shetland down to Aberdeen and audited them, and now everybody's doing them. And we've had to do it with COVID. The other thing I took myself off to be taught was how to give botulinus toxin, not for cosmetic reasons, for neurodevelopmental reasons, because injected into a stiff muscle, it would partially paralyze that muscle, and you could give children a much more easy gait. They could walk much more easily. I discovered that one of the adult physicians in Lerwick had worked with adult neurodisability and was familiar with botulinus toxin. And we worked together, and children in Shetland got that, which they also could get down in Aberdeen, because I'd started doing that at the Children's Hospital. So they were the three big innovations: Child Development Initiative, telephone consultations, and Botox. There was one, you asked if there was any differences in practice or diseases between mainland and Shetland. And there was one quite interesting one. I used to keep a card index of every patient I had in Shetland and Orkney and Aberdeen. And I kept a specific index of urinary tract infections and the results of investigations. The received wisdom at the time was, if you got a girl with a urinary tract infection, you treated the infection, kept an eye on her, and only investigated if it recurred 2 or 3 times. If you got a boy with an infection, trouble straight away. Investigate straight away. I looked at the results of my investigations. Sadly, I don't have the files anymore, so I can't tell you what the results were. But the funny thing was, the Shetland ones were completely different to Aberdeen, and they were very similar to a series that was published from Turnsberg in Norway by a paediatrician there. So your Shetland boys were much more Norse in their piddle infections than the Aberdeen ones. There was a very definite difference in the incidence of plumbing problems, shall we say. That was a funny general paediatric thing. Orkney came later, and it came later because Aberdeen's paediatric neurologist left. And she used to do a neurology clinic in Orkney. One of the other consultants in Aberdeen did a general paediatric clinic in Orkney, and I hadn't been into either of those. When the paediatric neurologist left, I was asked if I would be a sort of paediatric neurologist and do a clinic in Orkney. So I started doing clinics in Orkney and went through the same sort of process of development of those clinics as I've described for Shetland. I started off with just a clinical medical officer for company in the clinics, and I ended up with a sort of purpose organised child development centre at the Picky Centre, I think it was just down the road from the old Balfour. So I ended up doing clinics in that centre. Orkney was different to Shetland. The fishing was just as good. Orkney had ferry loopers, people who jumped on the ferry to escape things down in Scotland and England. And that could cause some problems. Shetland was just a bit too far away for most of that, but there were one or two problems that had resource implications. The funny thing about Orkney was when I was coming up to retirement, I was told about a brilliant child development centre that had been set up in Orkney, and would I like to go up and see it? So I pointed out to the bean counting manager that that centre had been set up on the basis of, you'll have to excuse the phone, had been set up on the basis of my centre in Raeden. So that was, they didn't even realise that Orkney had copied Raeden and had the cheek to suggest I go and look at the new centre up in Orkney, which was a backhanded compliment. Resources, you wanted to know about resources. The key to making this work was good links. The first good link was a good secretary in the islands. Now, my secretaries had varied, but I ended up, when I was leaving, with an absolutely brilliant one who was what she should have been graded as, a personal assistant. Because if you think about it, the budget that I ran in terms of what the patients that I saw cost in Aberdeen and in Orkney would have meant a medium-sized company, and the chief executive of that company would have had a personal assistant. So the first thing was a damn good secretary is needed, and there is one. The second thing that was needed, and Shetland did provide this, was accommodation, Bain's bairns, round the back end of the Gilbert Bain, so we didn't have to fight with the orthopods for the clinic anymore. So that was important. The other thing was the local link person, the Susan Bowie, who I'm sorry to say, I think is just about to retire. The problem of how to replace her, I will leave up to the managers, because I've been retired for nearly 10 years now, but keeping in touch with what goes on. And incidentally, the bean counters shut Raeden down within 2 years of me retiring. They waited till the old fart went, and then they realised it was a very expensive resource that wasn't equally distributed across Grampian. So it went. Anyway, that was that. So problems. Bit of lack of understanding by management. Could I start off with Shetland? I know that years ago, and this may be 15, 20 years ago, there was a problem when a new GP contract was introduced. And the GPs, as I understand it, or GPs were threatening to leave Shetland if they had to provide out-of-hours cover. The new GP contract gave them the option of not providing out-of-hours cover, and most of them took it. All the Lerwick ones did. Bray followed on. Ellswick didn't. The result of that was an increased influx of paediatric patients to the Gilbert Bain. So we went back to getting called to see patients on the ward while I was doing my clinic. That had been a problem in the early days, which had sort of subsided, and then it re-emerged, and then it got under control again. Basically, because of Susan doing regular clinics, I think once every 2 weeks or once a week. So that was a problem that I've got the feeling that management didn't always understand paediatrics in Shetland. And because they shut Raeden, they certainly didn't understand paediatrics in Aberdeen. I started the Raeden Centre. I had my own business manager who handled all the contracts and statistics and everything. And when she was replaced, of course, they downgraded the job to save money. And that person wasn't au fait, and I'd never been au fait with how the money was split between the local authority and the health board. So years later, there was a monumental stookie when they discovered that somebody owed somebody else around about 90 grand. But invoices for it had never been sent from the party of the first party, the party of the second party, and the party of the second party didn't know that they hadn't been getting them because there was no business manager. So it was that level of support. Anyway, I've rabbited on. I haven't given you a chance to ask any questions, so fire away.
It's the easiest interview ever when I can sit and listen to you talk. So I know that you've touched on a few of these things already, but one thing I wanted to ask about was the actual facilities of these places. And I know there was multiple places in Orkney, Aberdeen and Shetland, but when you were in, say, the Gilbert Bain or one of these clinics, could you describe a little bit about what they were like?
Right. Latterly, Bain's had its own entrance to the hospital, so the children didn't have to come in through the main entrance. They had their own waiting area, their own secretary, and they had 2 medical consulting rooms, and if I remember rightly, 2 or 3 therapy rooms, and then a therapy office. So that was Bain's. And I thought that was actually brilliant. Over time, the facilities in Shetland improved. When I started, if you needed a CT scan, south. Quite quickly, Lerwick got its own CT scan and an appropriate radiologist. I understand you're fundraising for an MRI scanner. And again, that would make, moving some people and children less of a problem. So that was the facilities. The other thing I didn't mention, and this delighted some parents, I would occasionally sneak off up the road to Bellsbrae and see children in school. I would check that the school teachers had switched off the insectocutors at the door so I didn't get fried as a foreigner by wandering in. And I would wander in and I would see some of the autistic children and so on in that environment. So they didn't have their environment changed, which always would change their behaviours. And I started latterly doing the same things down in Orkney. In Orkney now, it was only the last 3 years or so of working that I did clinics in Orkney, but in Orkney, I was in the general clinic. I had a room to myself. I didn't have a dedicated secretary there. I had the senior clinical medical officer there. And then we moved to the Child Development Centre down the road, which had got therapy areas, space for therapists, etc., and was a very much better environment. So there were improvements there. I know that the Balfour's been rejigged. I know nothing about the rejigged Balfour. All I know is that the medical records officers stopped keeping old envelopes for me, so my secret supply of Orkney postmarks has dried up. So that's, the environment.
Thank you. So another question I want to ask, and I know you've slightly touched on this when you were talking about urinary complaints, but are there any sort of particular medical problems that you noticed in Shetland or Orkney that wouldn't be so common, say, in Aberdeen, or vice versa? Were there any sort of medical aspects to being in these remote places?
Two things. First of all, it was a remarkable plus. And this isn't a disease. It was clinic attendance. It was 100% in Shetland. Everybody turned up because they knew if they didn't turn up, they had to wait 3 months for the next clinic. And when I first went to Shetland, my wife came up after the clinic and said, "Oh, there's a lot of kids in Lerwick." And I said that was because the paediatrician was in town. She noticed everybody was taking a day out. Now, the only other thing was on the neurological side of things, and that was MS. But that didn't impact on paediatrics particularly. And fortunately, it didn't impact on neurodevelopment because I wasn't looking after anybody with childhood MS. But that was those. The other thing about resource was there was one family that moved up with 2 very severe autistic children who moved into a property that wasn't totally suitable, and they used up the entire budget in Shetland for adaptations to houses for handicapped people for a year. And that was a genuine problem. And they stayed for 2 or 3 years and then moved away again because it wasn't quite the paradise that they'd been looking for. The effects of distance outweighed the benefits of a remote location. Grossness, which is pretty remote. Yeah.
Thank you. So I was just wondering, you've mentioned a few points about the Soothmouther that you are, which for anyone watching this who doesn't know means you came in through the south mouth. So essentially you're an outsider, or you're from the British mainland. And I was wondering, sort of joking aside, is that something which you ever felt people held against you, or made your work more difficult in any way?
Nobody ever held it against me. I got the impression, certainly in Shetland, that I was always welcome. That wasn't always the case in Orkney with the ferry loopers escaping social services, etc. But in Shetland, that wasn't a problem. There was one absolutely delightful incident in the days when we used the general clinic in the Gilbert Bain, when a lady came in and I said, "Hello there, welcome. Could you tell me what the problem is?" And the lady fired off into something. Now, I've been to Iceland 8 times. I actually used to speak a little bit of Icelandic, and that got me into trouble up there. But I couldn't understand this woman at all. So I turned to the nurse, who had got a nice Shetland accent, and said, "Can you help?" And she said, "No, he's from Wolsey. I'm from Bressay." Completely different accent. So the lady laughed and started napping, started speaking received pronunciation. That was the only time I had a funny one like that. I've never felt it held against me, certainly in Shetland.
Thank you. And sort of following on from that, I'm just wondering about, you've mentioned, as you say, the nurse with the broad Shetland accent. When you were working with other medical colleagues, whether were physicians or nurses, was it quite balanced between sort of Southmouthers or people from, mainland Scotland and Shetlanders, or were there a lot of people in your position?
I think it was. I've got to say, I think, for instance, well, I don't know for certain, but the people who were in the team had been up there long enough to have a Lerwick accent, or could slip into it. And I'm afraid I have an actress daughter, and I have a habit of swapping into the accent of whoever I'm talking to. So if I'm talking to somebody from Ireland, they start thinking I'm taking the mick. But I'm not. I just can't help it. So that was, I think the colleagues were a mix, but they'd all seemed to have adapted.
Thank you. So my next questions are more before I move on to my next questions, which are more about your broader view on medicine in sort of remote and rural areas. Is there any more sort of that you'd like to talk about in terms of your experiences in Shetland and Orkney? Or do
if you want to laugh, my first flight up to Shetland in the days of ATPs, which, as you probably know, the Shetlanders used to call another technical problem. It was officially the advanced turboprop. We were flying in on not the best of days to Sunborough, and the air hostess came on. "Ladies and gentlemen, those of you who are unfamiliar with this approach to Sunborough will notice the lighthouse above the plane on the right-hand side. This is perfectly normal, as is the sharp turn as we go past the lighthouse." And then very quietly, "and the sudden revving of the engines." So what had happened on that plane, to cause somebody to lose their bottle? But there was that message was given out for, I presume, until the management heard about it. And then it was stopped, but it was that was it. And of course, the taxi man, old man Sinclair, was always good at giving me the dirt on what my consultant colleagues were up to, and so on. Yeah.
Fantastic, thank you. So, as I mentioned, I'm going to ask you a little bit about your sort of broader views. So I wanted to start by asking, are there any particular skills which you think remote and rural practitioners need that might not be so needed in, say, Aberdeen or Edinburgh?
Well, there's a skill that's always needed in medicine, and that is empathy with the child and the family. And I think in the remote and rural, the empathy with the family is particularly important. So relating to the parents as well as the child. But in that, you've got to remember that your patient is the child, not the parents. Now, I do know in Shetland, there was one family where somebody declined Botox, where Jim Unsworth and I felt it would have saved him from crippling.
Thank you. So, following on from that, do you have any comments or thoughts on particular issues which remote and rural trusts face. So I know, for example, that there can be challenges around the recruitment and retention of staff, and I think you've slightly touched on that already, but do you think there are any particular challenges from these areas?
I think the recruitment of staff certainly was a problem, and it impacted on paediatric services when the general practitioner services gave up their full cover, if you like, and cover was moved to the casualty department at the Gilbert Bain. I think recruitment, you've either got to be a fisherman or have a particular liking for being up there. And I loved going off fishing if I got out of the clinic in time to let me do it. And I've seen me fishing on into semi-darkness because I couldn't.
Thank you very much. So kind of coming to the end here, but I wanted to ask, do you feel that practitioners in places like Shetland and Orkney have the sort of support and voice that they need in sort of big conversations about funding and resources and representation?
This answer comes from the physician's point of view, talking to colleagues. I've not felt that management has always understood the problems that the actual practitioners have. And I think I think you need a mix of management that's seen the wider picture and management that knows the local detail. So knows that you've got to have some sort of constant GP cover or equivalent for Unst, for example. And I'm not sure that that's always been the case. Down in Aberdeen, I don't think they understand. I've mentioned the personal assistant. I had a brilliant secretary down there who, for most of my time, who put up with my habits of having a paper file of every letter I've ever written on the island's patients. Okay, you could do it by computer now if you believed the computer wouldn't lose it, but I could get a phone call, and quite frequently did, from Susan Bowie when I went into the office at 8 o'clock in the morning, and I could have the Shetland patient's notes in my hand within 2 minutes from the office just across the corridor, and I could answer a query or suggest. But I don't think management in Aberdeen understood the workload that placed on the secretary in Aberdeen, and I think they felt that the islands should be paying for that side of the service. I didn't care for who paid for it as long as I could find the case notes. And if I couldn't find them, Sir Lancelot Spratt appeared.
Thank you. So my last question, which again sort of fits in with what you've just been saying, but if you could see any improvement to medical treatment or medical provision in the Highlands and Islands, what would you like to see? What would you like to see change?
I would like to see somebody that with extensive, this is in the context of a particular requirement that's coming up. I would like to see somebody in Shetland with paediatric experience on the ground who could support the visiting clinicians. The visiting clinicians would have to see the islands as a significant part of their job, not an add-on. Now, just about that, when I started doing the island clinics, I did 3 a year in Shetland. That was it. I ended up doing 3 a year general paediatric, 2 by 4 days child development initiative in Shetland, and doing 3 a year in Orkney. And I think my work in Aberdeen may have suffered as a result of that, because I was quite often away and nobody did the work in Aberdeen when I was up in Shetland. So I came back to a huge heap of case notes. Understanding, I think, is the key.
Thank you. So we've come to the end now. So well, thank you very much. But before we finish up, I just wanted to ask: is there anything else that I haven't asked you, or anything that you would like to cover?
I don't think so. I enjoyed my links with Shetland. I enjoyed mostly my links with Orkney. There were 1 or 2 families there that were, you all have them. And I think that is, you know, the heart sink families, as GPs would call them, are the reasons for the Shetland GPs not wanting to do their on call. But it was good.